Oncology, working at National Cancer Institute of Aviano in Italy. I will discuss about my work entitled Real-World Use of Erdafitinib in Urothelial Carcinoma, an Italian multicenter retrospective study. I would like to express my gratitude to Dr. Patrizia Giannatempo of National Cancer Institute of Milan in Italy for her guidance throughout this work and all the colleagues who have collaborated. Treatment landscape of metastatic urothelial carcinoma notably evolved in recent years. Fibroblast growth factor receptor alterations 2 and 3 are present in approximately 15–20% of metastatic urothelial carcinoma. Erdafitinib is a pan-FGFR inhibitor which demonstrated superior efficacy over standard of care chemotherapy in patients with selected molecular alterations after they have received platinum-based chemotherapy and immune checkpoint inhibitors. We have realized a multicenter retrospective observational study that involved 13 centers in Italy. This study aims to generate real-world evidence about treatment patterns, clinical outcomes, and adverse events management associated with the use of erdafitinib in routine practice, since data are limited outside clinical trials. Overall, 31 patients have been evaluated. Median age was 67 years. Primary site of origin was bladder in 58% of patients and upper urinary tract in 42% of cases. 64% of patients had de novo metastatic urothelial carcinoma, while in the remaining cases, patients developed a recurrence after radical surgery. Previous platinum-based chemotherapy was received by 99% of patients, with an overall response rate of 52%, while previous immune checkpoint inhibitors were administered in 84% of patients, with an overall response rate of 13%. In the overall population, median progression-free survival was 6.4 months, and median overall survival was 12.5 months, with a median follow-up of 24.1 months. Regarding safety profile, hyperphosphatemia occurred in 68% of patients, ocular adverse events in 48% of patients, and nail-related adverse events in 52%. The majority of adverse events were of grade 1 or 2. Subgroup analysis revealed that patient experiences these adverse events had numerically longer median progression-free survival and overall survival, although statistical significance was reached only for named adverse events concerning median overall survival. Among 22 patients who progressed on erdafitinib, 23% received further treatment with enfortumab vedotin. Median overall survival in this subgroup was 25.7 months with subsequent enfortumab vedotin and 25 months in the group of patients receiving other treatments. Only one patient received enfortumab vedotin before erdafitinib. In conclusion, our study highlighted that survival outcomes with erdafitinib and adverse event profile in this real-world context are consistent with clinical trial data. Although no head-to-head comparison is available, survival outcomes with erdafitinib following platinum-based chemotherapy and immune checkpoint inhibitors are at least comparable to those reported in literature for enfortumab vedotin following immune checkpoint inhibitors and platinum. The advent of the combination of enfortumab vedotin plus pembrolizumab in first-line setting is changing current algorithm. Therefore, the treatment paradigm for FGFR-altered cancer patients is a field of significant interest, and further studies are needed to define the best treatment sequence. Thank you for the attention.